What's up, Ninja Nerds? In this video today, we're going to be talking about pulmonary valve disease. We're going to talk about pulmonic stenosis and pulmonic regurgitation. If this video helps you, if you learn a lot, if it makes sense, please support us. And the best way that you can support us is by hitting that like button, commenting down in the comment section, and most importantly, subscribing. Also, if you guys want some amazing notes and illustrations to follow along with during this video, go down in the description box below. We'll have a link to our website where you guys can check that out. All right, let's start talking about pulmonary valve disease. So with pulmonary valve disease, we have pulmonic stenosis and pulmonic regurgitation. So our question that we have to ask is basic definition between these two. So pulmonic stenosis, the problem with this disease process is that the pulmonic valve, so the pulmonary semilunar valve is the valve that's actually forming, preventing a backflow from the pulmonary artery back into the right ventricle. In patients who have pulmonic stenosis, normally you want your blood to flow from the right ventricle and into the pulmonary artery. But in patients who have pulmonic stenosis, their valve is very, very fibrotic, it's very thick, it's very sclerotic, and it doesn't want to open well to allow blood to exit out of the right ventricle into the pulmonary artery. And so you know why that's important? At what point in the cardiac cycle is the blood trying to leave the right ventricle and going to the pulmonary arteries? During ventricular systole. So in this process, what I want you to know is during ventricular systole, this disease process struggles to get blood from the right ventricle into the pulmonary artery due to this fibrotic or stenotic pulmonary valve. The question we have to ask a little bit later is what causes that fibrosis, what causes the narrowing of that pulmonary valve that prevents blood from leaving the right ventricle. And we'll do that in a little bit. With pulmonary regurgitation, and pulmonary regurgitation or pulmonic regurgitation, again, here is this pulmonic valve designed to be able to prevent backflow from the pulmonary artery into the right ventricle. Now, if someone is having regurgitation, that means that these valves are not creating a good seal. If they're not creating a good seal, that creates a space between the pulmonic valves during what phase of the cardiac cycle? During diastole. So when the ventricles are in what's called their relaxation phase, are they in what's called a diastole. Blood is supposed to be filling into the ventricles, but blood should not be filling the ventricles coming back this way from the pulmonary artery back into the right ventricle. It does though in pulmonary regurgitation because the pulmonic valves do not form a good tight seal and blood can leak backwards from the pulmonary artery into the right ventricle. So that begs the question, what causes that fibrotic or stenotic pulmonary valve where it doesn't want to open, it's stubborn and doesn't want to allow blood to move from the right ventricle out into the pulmonary artery? So this process is being inhibited. That's a great question. And you know what? It's commonly congenital. It is most commonly going to be congenital. And what do I mean by this? There's a couple different conditions that is most commonly associated with patients who have pulmonic stenosis, and you need to remember these. The first one is something called tetralogy of Fallot. Tetralogy of Fallot is they have 4 different types of defects that involve their heart. What are those defects that you see in tetralogy of Fallot? The first one is you see what's called right ventricular hypertrophy. You see what's called a high riding aorta, so we'll put an overarching aorta, and it's high riding. You also see something called a ventricular septal defect, and you also see pulmonic stenosis. And this pulmonic stenosis is very interesting because sometimes it'll involve the valves, but sometimes it'll involve like this part just below the valves, which we call like the infundibulum of the pulmonic trunk. Sometimes there can be narrowing of that area. Either way, the same thing kind of effect occurs here is you're narrowing that right ventricular outflow tract. So in patients who have what's called tetralogy of Fallot, it's just a congenital condition, they have a high risk of pulmonary stenosis along with these other associated conditions. Another one that I want you to remember, let's do it in a different color. This one is called Noonan syndrome. You're like, what the heck? Noonan syndrome is an interesting one as well. And in this syndrome, these patients have some type of genetic condition that predisposes them to a couple different types of things. You can remember another tetrad. Usually in this situation, these patients have a short stature. So if you see a child with short stature who has intellectual disability, who has what's called hypertelorism. You're like, what the heck? What is hypertelorism? Hypertelorism is kind of one of the giveaways, is that they have a large distance between their eyes. So there's a large space between their eyes. Sometimes they may also have what's called a webbed neck. But last but not least, they also have an association of their pulmonic stenosis. And a lot of these problems is just that the pulmonary valve, it just irregularly forms. It becomes irregularly shaped and becomes a little bit more susceptible to fusion and fibrosis. The last one that I want you to remember is something called congenital rubella syndrome. And this is the third one that is also seen in patients who have pulmonary stenosis. So congenital rubella syndrome is obviously due to the rubella, particularly one of the infections that you can get when you're a younger child, right? Particularly during the birthing process, there's a lot of risk for this particular pathogen. So in congenital rubella syndrome, this is usually a triad. And we remember these triad via the 3 C's. So one of them is that they have a high risk of cataracts. They have a high risk of cochlear defects. So in other words, they have hearing loss. And then they have cardiac abnormalities. And these include patent ductus arteriosus and pulmonic stenosis. So my friends, we've obviously gotten an overriding theme between these, that in patients who have pulmonic stenosis, the most common cause is some type of congenital abnormality seen in tetralogy of Fallot, Noonan syndrome, and last but not least, congenital rubella syndrome. Now that we've talked about that, the next one is to talk about pulmonic regurgitation and some of the causes there. All right, so pulmonic regurgitation, again, what is the problem here? Pulmonic regurgitation is that these valves are not forming a tight seal as compared to stenosis where they're super stiff and they don't want to open. And these, they're really floppy, they don't form a great seal, and it is easy for blood to flow back into the right ventricle. During what phase? During ventricular diastole. It's not supposed to be going back in there. What kind of conditions can increase the risk of that kind of process? You know, it's really interesting. If someone has, this is, believe it or not, the most common cause, someone has one of these pulmonic stenosis. Usually it's tetralogy of Fallot, since it's one of the more common out of those 3. So they have pulmonic stenosis. One of the treatments for pulmonic stenosis is you take this kind of like catheter, and what you do is you want to try to, and a patient who has pulmonic stenosis, you want to try to inflate and push open and stretch open that very fibrotic and stiff valve. And so what they'll do is they'll put a balloon in there called a balloon valvuloplasty and open this area up. When they do that though, they may open it so much that now it's easy for it to leak back in because there's not a good seal. And so in patients who have pulmonic stenosis, which one usually is this associated with? Tetralogy of Fallot tends to be the more common one. These patients, after they receive what's called a balloon valvuloplasty, they're at high risk now of developing regurgitation. So that is an important thing to be able to remember. Okay, what's another one? Another particular cause besides having post, again, this is usually after having status post balloon valvuloplasty. Another one is you develop some type of lesion that is actually causing destruction or erosion of that valve. What kind of condition would do that? You know, there's a nasty pathogen in a patient who has what's called infective endocarditis. Infective endocarditis. And infective endocarditis, particularly patients who are IV drug abusers, they're at high risk for being infected, especially from the right side of the heart, by Staphylococcus aureus. It tends to affect the tricuspid valve more commonly since it's the first one that gets hit. But if it tends to bypass and kind of extend onto these valves, they can form little vegetations on the valve and then erode and erode and erode away the valve. If you erode that valve away, it's going to be really easy, because you're not forming a tight seal, for blood to just backflow right into the right ventricle and cause pulmonic regurgitation. So this would be another one. So you want to see this in patients who have infective endocarditis. This would actually be the second most common cause. The first most common cause is someone who's actually status post balloon valvuloplasty for pulmonic stenosis, and then they develop pulmonic regurgitation. And the last one here is really rare, but I might as well mention it. You know, there's a condition called carcinoid syndrome. Usually you see this with like neoplasias that involve the lungs or that involve like the GI tract. So sometimes if you have like a neoplasia that involves the lungs, sometimes if it involves the GI tract, you develop these cancers. So you develop like a tumor of the GI tract, or you develop a tumor that's involving the lungs. And what happens is these tumors have the ability to have a paraneoplastic type of function where they secrete lots of what's called 5-hydroxytryptamine. This is basically serotonin. And so it'll increase the production of a molecule called 5-hydroxytryptamine through this paraneoplastic fashion. The problem with all of this serotonin is that this loves to go and act on these valves and then trigger a type of mechanism here, which is very interesting. It triggers fibrosis. So it causes all these fibrous deposition to form on these valves. Now you would think, well, that sounds like it would be more likely to cause pulmonic stenosis. In some cases, it can cause pulmonic stenosis. It's just for some reason, from what the literature has shown, is that because they become more fibrotic, it's tough for them to actually have their leaflets touch one another properly and close off and form a good seal during diastole. So they're most likely to keep a little bit open so blood can still get out, but because whenever they go into diastole, the valve kind of leaflets don't actually completely coapt or touch one another or seal off right, it creates an opportunity for blood to just empty right back into the right ventricle. What is this condition that's due to these high levels of serotonin due to these neuroendocrine tumors? This is called carcinoid syndrome, and this is the third most common cause of someone developing pulmonary regurgitation. So by far, one of the most important ones to remember is balloon valvuloplasty, infective endocarditis, and last one is carcinoid syndrome. For tricuspid stenosis, it's a congenital abnormality, most commonly tetralogy of Fallot, but it could also be Noonan's and congenital rubella. Let's move on to clinical features and physical exam findings. All right, so let's talk about pulmonic stenosis, the clinical features and physical exam findings. So when a patient has pulmonic stenosis, the problem is getting blood out of the right ventricle into the pulmonary artery. We already know that, right? So because this valve is just super stiff, it's fibrotic, it just doesn't want to allow for us to push blood through it, right? So not as much blood is getting out. Okay, that's the problem. So this develops an issue where the right ventricle thinks like, okay, the pressure in the pulmonary artery must be so high or something that maybe I just got to get a little bit stronger. I got to get a little bit more hypertrophy. I got to jack it up a little bit. And then if I get stronger, I can generate more pressure and push more blood out of the right ventricle and into the pulmonary artery. That's what I'm going to do. And so that's what the right ventricle starts to assume. And so what happens is because it's having to push against this very narrow valve, this thing starts getting all roided up and jacked. And it comes back just like, hey, baby, how you doing? And when it comes back all jacked and ready to contract, what's this called whenever your ventricles have gotten a little bit more thicker in that sense? Right ventricular hypertrophy. And so because of that pulmonic stenosis, these kind of patients develop right ventricular hypertrophy as a particular clinical manifestation. Why is that bad? With right ventricular hypertrophy, their ventricles get thicker and it's more difficult for them to fill, right? So they can develop what's called a diastolic dysfunction. So with this right ventricular hypertrophy, it gets thick, narrows the lumen, and it's harder to bring blood into the right ventricle. So this can create what's called a diastolic dysfunction. The problem with that diastolic dysfunction is that this can lead to right heart failure symptoms. You're having difficulty with being able to fill blood into the right side of the heart. If you can't fill blood into the right side of the heart, it's going to start backing up into the inferior vena cava, superior vena cava, and lead to right heart failure. Pretty straightforward and simple, right? Okay, what else? Here's the other thing. Our poor little right ventricle has to push as much blood as it can, and maybe it's just not getting enough blood that's going through the pulmonary arteries. Where do the pulmonary arteries take blood to? The lungs. What do the lungs do? Oxygenate the blood. If we're not getting enough blood to the lungs, we're not oxygenating enough of that blood, that can lead to hypoxemia. Potentially, that can lead to clinical manifestations such as cyanosis or shortness of breath. And so another particular thing is that there may be decreased oxygen delivery. So there may be less oxygen that's being actually occurring, particularly within the lungs. So less oxygenation, okay, that is occurring. And this is an issue because less blood flow is going from right ventricle to the pulmonary arteries. That means less of that blood that's going through the pulmonary arteries is actually getting oxygenated. And the particular clinical manifestation that we may see with that is cyanosis, especially since what is the most common cause of pulmonic stenosis? Usually congenital heart diseases. We may see children who have bluish discoloration of like the mucous membranes, the lips, and things of that nature. So that's an important thing to think about. Okay, so now let's talk about what right heart failure symptoms would look like. It's pretty straightforward, right? And then again, we'll go back over this kind of cyanosis thing and add on something else as well. Okay, so we have a patient who has right heart failure symptoms. What would that potentially manifest as? Well, if the right heart is not working because there's a diastolic dysfunction, the particular thing here is that blood is going to back up superior vena cava, back up inferior vena cava. If it backs up superior vena cava, that's going to back up into the jugular vein and cause jugular venous distension. If it backs up into the liver, into the spleen area, it can cause hepatosplenomegaly. We'll put hepatomegaly since that's the more common thing to occur first. If it backs up into it causes fluid to accumulate in the peritoneal cavity, that's called ascites. And if it backs up and accumulates within inside of the particularly within to the lower extremities, it may cause something like pedal edema. Now, the other thing that you want to take into consideration is because that actual right ventricle is becoming more hypertrophied, it's getting jacked, baby, the atria is going to have to work harder to pump blood into it. And so it's like, all right, I got to get jacked too. And so sometimes it can get jacked and up as well within the right atria and try to contract and push blood down into the ventricles whenever it's going through its diastolic process. And so sometimes if the atria has to work harder in hypertrophy and create a stronger kick to push blood from the right atrium down into the right ventricle, especially during ventricular diastole, it may produce a characteristic S4 heart sound. And so sometimes you may also hear this as well. But stick with the right heart failure, definitely. Okay, what about the next thing? Okay, the next thing we said is there could be some evidence of cyanosis, right? So why is this an issue? So you think about that problem, right, where there is, again, this very, very stenotic fibrotic valve. I'm trying to push blood from the right ventricle, go to the right, to the pulmonary arteries. From the pulmonary arteries, I want this to take blood to the lungs. The whole job of the lungs is to take that blood and put oxygen into it and send that back to the left side of the heart. From the left side of the heart, it'll get pumped out into the systemic circulation and get delivered to the body. If this process is not occurring because we're not getting enough blood to the lungs, less of it's getting oxygenated, less oxygen is going to be occurring with it, less oxygen will be bound to the actual hemoglobin of our red blood cells. And that can present as that bluish discoloration. Okay, bluish discoloration. And that is important to remember in this episodes of cyanosis, especially for these children. Here's one more interesting thing that you can also see. These valves, right? They're so dang fibrotic and stiff, and they start to kind of fuse, right? And when they fuse via this process called commissural fusion, you make these little spaces where blood has to move through really tiny. Imagine a poor little pesky red blood cell that's just trying to go about its way and pick up oxygen. It has to run through that tiny little space. When it does that, it gets shredded into pieces. What is that called? When you just shred or lyse open your red blood cells, not due to some type of like process that's actually like macrophages or anything like that. It's due to the valve. This is called microangiopathic hemolytic anemia. So sometimes we call this MAHA. And so you may see something called microangiopathic hemolytic anemia, and we would be able to tell this, but if we went through and said, okay, they have some anemia, they have elevated amounts of LDH, low haptoglobin, low hemoglobin, and they have schistocytes on their blood smear, that could be indicative. But the big things that I really want you to remember for symptoms of pulmonic stenosis is right heart failure, cyanosis, maybe if you want to take the extra step, remember MAHA, but here's the big thing. If we have a patient that comes in with some mild right heart failure symptoms, the one thing we want to go doing is taking a listen to their heart, listening for any types of murmurs. Let's describe that and take a listen to what it may sound like. All right, so what is this particular heart sound that we would hear in pulmonic stenosis? So again, remember, what is the issue? This valve, super stenotic, okay? Doesn't want to let blood flow, try to squeeze through a tiny little baby opening that you may have within this valve. So let's make like a tiny little opening here, right? Tiny little opening. And I'm going to try to squeeze as much blood as I can out of the right ventricle into the pulmonary artery. When I do that, at what point within the cardiac cycle would that heart sound or heart murmur be present? Well, what is it called whenever the ventricles are contracting? Ventricular systole. So this would be a particular type of systolic heart murmur. That's the first thing I know. So if I know it's systolic, it has to be between S1 and S2. So again, S1 is whenever the tricuspid and mitral valve closes. S2 is going to be when the pulmonic and aortic semilunar valves closes. And then again, back to tricuspid and mitral. Now, if that's the case, then I want this valve to open when I'm pushing blood through it, but it doesn't do a good job of it. And so what happens is the right ventricle has to work really hard to push as much blood as it possibly can through that tiny little opening. And it may do it just enough that it clicks that valve open just a little bit. And we call that, you hear what's called an ejection click. So I'm going to put that right here. You'll hear something called an ejection click. And that is basically the quick snapping open of the pulmonic valve just a little bit for blood to squirt through that area. Then, after it does that, blood will start rushing through this area. Usually, it's going to be the most blood running through it during the beginning phases of systole. And so it'll start rising up and becoming louder, louder, louder. And then, what happens is, the blood flow, as it's continuously flowing through that pulmonary valve, starts decreasing because less blood is being left in the ventricles as you go through systole, right? So as you're going through systole, you're hoping that you're squeezing, pushing blood out, that there should be less blood that's moving across that pulmonic valve as systole continues. And so the increase in sound will occur in the early phases, and then after that, it'll slowly start to go down. And it makes this classic type of kind of look here that we see, and we call this, when the sound is going up, where there's a rising or increase in the intensity of the sound right after the click as it passes through the pulmonic valve, that's called crescendo. So this part here is called crescendo because it is increasing in intensity as the blood flows across the pulmonic valve. And then as less blood is leaving the right ventricle, the sound should actually decrease in intensity. And that is called a decrescendo. So decrescendo sound. That means the intensity of the sound is decreasing as less blood is flowing across that pulmonic valve. So in these patients, they have what's called a systolic ejection click followed by a crescendo decrescendo murmur. Where would you hear this? Usually left upper sternal border, like along the second intercostal space. So you may hear this along like that left upper sternal border, which is particularly like the left second intercostal space. Here's the next thing. What can I do to augment the intensity of that murmur? Well, the question is what if I bring more blood into the right side of the heart? If I have more blood in the heart, I have more blood that I have to push through that pulmonic valve. Do you think if I have more blood to push through the pulmonic valve, that could potentially increase the intensity? Yes. So it's going to increase the intensity and the actual duration of the murmur. And so what I want you guys to remember is anything that we can do to increase the blood flow into the right side of the heart would increase the intensity of the murmur. What are the things that increase the venous return to the right side of the heart? Do you guys know? So we can increase venous return via a couple ways. We can increase venous return via inspiration. So this will increase the intensity of the murmur if I have them take a deep breath in. Because if I have them take a deep breath in, they'll pull more blood into the right side of the heart. The other thing is squats. So if I have them squat down, that'll increase the venous return. Or if I have them do something called a leg raise, that'll increase the venous return to the right side of the heart. So you have to remember these things, okay? So if I go and I listen to a patient's chest and I hear around the left second intercostal space, I hear a click right at the beginning of systole, ventricular systole, followed by an increase in intensity of the sound, followed by a decrease in the intensity of the sound, crescendo, decrescendo. And I have them take a deep breath in and the murmur is increased, or I have them squat down, the murmur is increased, or I have them lay down flat and I lift their legs and the murmur increases. These are classic findings of pulmonic stenosis. Now that we've talked about that, let's go talk about pulmonic regurgitation. All right, so let's talk about pulmonic regurgitation. So in these patients, what is the primary issue? Well, think about it. In these issues, that valve is all kinds of floppy and loose, and it's just not allowing for a good seal. So because of that, blood will continue to flow back into the right ventricle. So imagine you're just getting hit with constant volume of blood back into the right ventricle, back into the right ventricle, back into the right ventricle. The right ventricle's like, I can't take all of it. What am I going to do? It says, I got to make room. I'm going to balloon up like the Michelin Man. And so it dilates to accommodate that large volume. And so what it'll do in response to having all of that blood constantly fluctuating back into the right ventricle, it's going to get volume overloaded. And so it says, all right, I'll accommodate for it. And he says, I'm going to dilate this sucker so I can accumulate more blood in this right ventricle because everything keeps coming back into me. So what do we see in this situation? In this patient, they develop the exact opposite. They develop what's called right ventricular dilation, and this is due to that volume overload. In that situation, because their ventricles dilate, their ventricular walls get super thin and they lose good contractility of their ventricle. So in that situation, they develop something called a systolic dysfunction. They're not good at pumping blood out. So they get kind of volume overloaded, they get very thin. So they undergo what's called eccentric hypertrophy, where the myocardial cells actually get bigger, but in length. Whereas in this condition, pulmonic stenosis, they undergo concentric hypertrophy. They get bigger and they have their sarcomeres get added in a parallel fashion. Whereas in this condition, it's eccentric, they get added in series, right? So because of that, they lose a good contractility and their systolic function starts to decline. They can't pump blood out of the right side of the heart, and it backs up into the superior vena cava, inferior vena cava, and leads to your classic right heart failure symptoms. Pretty straightforward for these cases. There's not much else that we're really going to be talking about for this one. So we'll talk about that, and then we'll talk about the murmur that they have. So since they have right heart failure symptoms, my friends, we've already covered this in great detail. This should be straightforward. Backs up into the superior vena cava, they get JVD. Backs up down to the inferior vena cava, they get hepatomegaly. They can get some spleen involvement. Backs up into their peritoneum, causes ascites. Backs up in the third spaces into the peripheral tissues, causing pedal edema of the lower extremities. Now, because this ventricle is dilated, what happens is it can accommodate a lot of blood that can rapidly flow down into it during early diastole. And so when a lot of blood is rapidly flowing down into your ventricles during early diastole, it can make a lot of turbulence flow and cause the classic S3 type of heart sound in comparison to the S4 in right ventricular hypertrophy, which you see in pulmonic stenosis. Boom, shakalaka, we good. All right, what else? Now that we hit the right heart failure, the next thing is we have to say what can be the murmur. We have to know the descriptions of the murmur. We have to listen to the murmur. So let's go ahead and hit that hard. So we have that murmur for a patient with pulmonic regurgitation. The issue with this one is that valve is, again, not giving me a good seal, and blood is consistently flowing back from the pulmonary artery back into the right ventricle. Now the question is when does blood normally, when would you want blood to be going back into the ventricles? You'd want blood to be going into the ventricles during diastole, but you don't want it to be coming back from the aorta, the pulmonary artery. You want it to be coming from the atria. But if blood is kind of backflowing and the ventricles are not in systole, they just finished systole and pushed all that blood out, and blood starting to backflow into the ventricles, this is occurring during diastole. So this would be a diastolic type of murmur, meaning we would hear it when? Well, S1 is the closure of the mitral and tricuspid, so that's usually going to start the onset of ventricular systole. S2 is the closure of the aortic and the pulmonary semilunar valve. Well, that's when this sucker is supposed to be closing. It's right around S2. So that starts the onset of ventricular diastole. So between S2 and S1 is when I'm going to hear this. When the blood flows backwards, it starts flowing, and it usually is the most intense as it actually is going from the pulmonary artery back down into the right ventricle. So it tends to have kind of this down-going type of intensity. So right when you notice that the blood is flushing back into the right ventricle during the early stages of ventricular diastole, the blood will flow back down rapidly, and then it'll flow a little bit slower through that valve, and a little bit slower, and a little bit slower, and a little bit slower. And so the sound intensity will decrease. So since it is going down, the intensity is going down from the beginning of diastole towards the end of diastole. What do we call that when the intensity is going down? Decrescendo. So this is a diastolic decrescendo murmur, meaning that it occurs during diastole between S2, S1, and it would be going in an increased intensity downwards throughout the process. So the intensity would actually be decreasing throughout the process of ventricular diastole. Where would you hear this? You would usually hear this around the left upper sternal border, so usually like left second intercostal space. And the other thing that's important for this one is what do we do that increase the intensity of the murmur? I can increase the intensity of the murmur. Every right-sided murmur intensity is increased by what physiological process? I've already said it 1,000 times. Inspiration. You can always increase the intensity of right-sided murmurs with inspiration. Why? Whenever you take a deep breath in, your intrathoracic pressure drops, you suck blood into the right side of the heart, the volume on the right side of the heart is increased. If the volume on the right side of the heart is increased, when I push blood out of the right side of the heart, guess where all that volume is going to go back to? Right back into my right ventricle, increasing the intensity of that sound. So if inspiration brings more blood into the right side of the heart, and that increases the intensity of the murmur, anything else that increases venous return is going to increase the intensity of these dang murmurs. So what would increase the intensity increase my venous return to the right side of the heart. This would be if I do a squat. This would be if I do a leg raise, or I'm laying down flat and I have someone do a leg raise. These could be things that increase the venous return, increase the intensity of the murmur. Otherwise, if you had someone that was actually not squatting down, they were standing up, or you have in the Valsalva, that's going to decrease the venous return to the heart, and that will decrease the intensity of the murmur. Boom, shakalaka. Let's move on to the diagnosis. So let's talk about the diagnosis of the pulmonic stenosis and the pulmonic regurgitation. So it's actually straightforward. We have that patient again. Both of them may present with some degree of right-sided heart failure, right? So again, you may see right-sided heart failure with a JVD, hepatomegaly, ascites, pedal edema, so on and so forth. May have an S3, particularly in the which type? Well, with a systolic dysfunction, that would be the pulmonic regurgitation. S4, particularly in the right ventricular hypertrophy, which would be the pulmonic stenosis. Again, you may see cyanosis in the pulmonic stenosis. But again, when you're listening to their heart, and patients who have pulmonic stenosis, they may have a particular type of murmur where they have an ejection click followed by a crescendo decrescendo murmur. Again, left intercostal space, particularly second intercostal space. If they have pulmonic regurgitation, they may have a diastolic type of decrescendo murmur. We also call that a Graham-Steele murmur. Don't forget that, Graham-Steele murmur. And again, both of them can be increased intensity with a venous return and an inspiration. Now, that may help us, but we want that echo because that's going to tell us what's going on. So we get the echo to really validate that blood flow. When we look at pulmonic stenosis, the problem is being able to get blood from the right ventricle into the pulmonary artery. It's just not happening. And so what we do is we throw on color Doppler. And we throw on color Doppler, what we'll see is we'll see a decreased amount of blood flow that's moving across the pulmonic valve. Particularly during what phase? During ventricular systole. And that is one of the big things. So there'll be a decreased amount of velocity moving, there'll be a decreased amount of blood flow that's moving through the actual pulmonic valve during the systolic process. The other thing is if you have all of that high pressure, again, you may also see something else, which is that right ventricular hypertrophy. Now with pulmonic regurgitation, you're also going to see that these valves are just not forming a great seal. So blood is flowing backwards into the right ventricle during diastole. And so you're going to see an increased amount of blood flow across the pulmonic valve during diastole. And if that is the case, you're going to cause the overload of that actual right ventricle to the point where it might undergo right ventricular dilation. And so these are things to be thinking about, is looking at the blood flow, looking at the different movement of the blood across those valves when they should not be flowing across the valves. Usually during diastole is regurgitation, and when they're not flowing enough across that valve during the systole is going to be pulmonic stenosis. We hit this hard. Now let's finish off with treatment. All right, so let's talk about the treatment of these pulmonary valve diseases. It's actually straightforward. Again, what were the most common clinical features that you would see in these patients? We may see right heart failure. Oftentimes these patients are asymptomatic. However, if they start developing symptoms of right heart failure due to the right ventricular dilation that's causing the systolic dysfunction, the right ventricular hypertrophy that's causing the diastolic dysfunction, you see evidence of cyanosis, yes, you'd want to consider treating those things, right? And so how would we treat heart failure? It's relatively simple. In these patients, they're overloaded usually into their systemic system, particularly on the venous side. So they have systemic venous congestion. We want to relieve that congestion. And the best ways that we can do that is by trying to fluid restrict. And so we may restrict some fluid intake to prevent any kind of worsening of that actual edema. The other thing that we can do is we can restrict sodium, because sodium allows for us to retain lots of fluids as well. And then if we start to get kind of like the higher volume overload kind of states, we can consider something like diuresis, giving things like furosemide. The other things that we want to do is if they start to get a lot of the pedal edema, we can actually help to increase the venous return from that lower extremities upwards by utilizing different types of compression stockings as well. So these are things that we can do to treat these patients with the heart failure. Now, if they're having heart failure, because their actual pulmonic regurgitation or pulmonic stenosis is getting worse, it's in the moderate to severe categories, and we're treating them not really getting better, we may progress to doing some type of valvular process here. So what would we do then? Well, the first thing that we would do, particularly in patients who have something called pulmonic stenosis. So in pulmonic stenosis, we can treat patients with what's called a balloon valvuloplasty. So what that means is I'm taking a balloon, I'm taking a catheter, threading it down through the right atrium, right ventricle, and up into this area of the pulmonary trunk where the pulmonary valve is. I'm going to take this balloon, fit it between that little space between the valves, and just blow that sucker up. And when I blow the balloon up, it's going to inflate, and try to push open the actual leaflets so that you can create a nice opening space for blood to just rejet through between the right ventricle into the pulmonary trunk now. And so that's the whole design, is to be able to open up the pulmonic valve. So we would do this kind of as a first-line treatment in patients with pulmonic stenosis who are developing symptoms of right heart failure. Now, if they're having right heart failure, you've tried the balloon valvuloplasty for pulmonic stenosis, and they're not getting any better, you can then progress to a valve replacement. Usually patients who have significant pulmonary regurgitation, and they're having symptoms of heart failure, we may go straight to a valve replacement. But we try balloon valvuloplasty for pulmonic stenosis first. So if you have pulmonic stenosis refractory to medical therapy and balloon valvuloplasty, or you have severe pulmonary regurgitation with right-sided heart failure, then you can go to valve replacement. Now there's two different types of valve replacements that we could utilize in these patients. We could remove this valve and replace it with these two. One is called a mechanical valve. So a mechanical valve, one of the interesting things about mechanical valves is that they last a long time. They're very good. They have a long lifespan. So one of the things I want you to remember is they have a very long lifespan. However, there is a particular downside to these. Because you're giving a mechanical valve, they have a long lifespan, but they require lifetime anticoagulation. They're highly thrombogenic. So because they have high risk of thrombi, because they're thrombogenic, you may have to put these patients on anticoagulants. So lifelong anticoagulants. And usually the most common one that's been FDA approved for valvular diseases, particularly with a mechanical heart valve, is warfarin. And so we may have to use something like warfarin, and if they won't tolerate warfarin, we can consider something like aspirin. So generally, because it has a long lifespan, highly thrombogenic, we would prefer, because it has a long lifespan, to use these in patients who are younger, but also because you're giving them anticoagulants because they're highly thrombogenic, you'd prefer this in patients who do not have a high bleeding risk, or they're already taking anticoagulants for some other reason. So generally, the preferred population is less than 65 years of age, and those who already are on anticoagulation, like for example, they have AFib, or are on anticoagulation because they fit perfectly because they're going to need it anyway. So that will be one particular indication for mechanical valve replacement, particularly for the pulmonary valve. The other one is called a bioprosthetic valve. So this one is called a bioprosthetic valve. Now a bioprosthetic valve is usually some type of bovine type of replacement here, where we're not using mechanical types of structures. We're utilizing something like a pig, or kind of like a pig component of a valve as well. In those situations for bioprosthetic valves, these do not have a long lifespan. They're the exact opposite. They have a short lifespan. And usually they're about 10 years, and then you have to get them replaced. So that's one thing. So would you want to give this to patients who have, very young and they're going to need it for a long time? They got to get another surgery? No. So that's one particular thing to think about. The other thing is that it has a low risk of thrombogenicity. So it has a low thrombogenic risk. So because of that, because it's not super thrombogenic, you don't require anticoagulations for a lifelong time period, only a short period of time. So generally you'll utilize anticoagulants for about 3 months on these patients, and then they don't need it really anymore. So because of that, think about this. These patients, since it has a short lifespan, about 10 years, and it has to get replaced, it'd be good for people who are old, so greater than 65 years of age, or it'd be good for patients who have a high bleeding risk or are not really on anticoagulation. So high bleeding risk, we would not want to put them on this type of valve because then they have to be on anticoagulation. That's not a good thing. We would want to give them this one if they have a high bleeding risk. The other thing that you do want to remember, especially for bioprosthetic valves, is that yes, they may have a low thrombogenicity, but they have what's called a high risk of what's called prostatic valve endocarditis. And what that means is that they can get infection of this bioprosthetic porcine valve or bovine valve. And in those situations, we have to treat that with antibiotics. So sometimes we may prophylactically treat these patients with what's called amoxicillin. Okay? And so that is an important thing to remember. Now that we've talked about all of these things for the pulmonary valve stenosis and regurgitation, I hope all of this is made clear and understandable and you enjoyed it. If you guys did, please hit that like button and subscribe. Ninja Nerds, as always, until next time.